You may not know this, but in Taiwan, cardiovascular disease kills more people than cancer. And what's worse, it's not taking the elderly. It's taking breadwinners in their 40s and 50s. The day before they collapse, they may seem fine. One key marker of cardiovascular risk is artery clogging LDL cholesterol. And the hard part is diet control, exercise, even prescription medicine. And still, many people can't get LDL to a safe level. Good news? There's a treatment that targets the source of LDL production. Just one shot every 6 months still works. I'm Jung-Ding Jing. Today, we'll break down why your LDL won't go down and the options that may help so you can choose what works best for your blood vessels. So let's use science as the key to unlock a long, healthy life. There are many risk factors for heart disease and stroke. The most critical one is elevated LDL cholesterol. But how is LDL formed? Think of lipid production as a huge delivery network. After a big holiday meal, the fats you eat, triglycerides, cholesterol, are not water-soluble, so they need a ride in. Your small intestine packs them into a huge truck called a chylomicron. It moves through the lymphatic system, circling around. Along the way, an enzyme called LPL offloads triglycerides to muscles, fat cells, and other tissues for energy. Once unloaded, it's an empty truck and goes back to the liver. But besides dietary fat, the liver also makes triglycerides and cholesterol. These are packed into another truck called VLDL, or very low density lipoprotein. In the bloodstream, VLDL keeps unloading triglycerides, getting smaller until, eventually, it becomes LDL. LDL is like a small but long-range delivery scooter, a cholesterol courier. Its size makes it perfect for delivering cholesterol to tiny vessels, nearby cells, and other spots to repair cell membranes or make hormones. But the problem is, if there's too much LDL in your blood, because it's so small, it can slip into vessel walls and get stuck there. Once it gets in, it gets oxidized into oxidized LDL, which triggers inflammation and draws in immune cells, forming the dreaded atherosclerotic plaque that can block arteries and lead to stroke or death. We did an episode on how blood sugar swings can actually lead to plaque rupture. Interested? Check the link in the description. Back to LDL. What level is safe? According to the 2025 Taiwan Lipid Management Consensus, the answer is, it depends. Sounds vague, right? The higher your cardiovascular risk, the lower your LDL should be. And within a safe range, lower is better. The lower, the better. In plain terms, if you don't have hypertension, diabetes, or a smoking habit, your LDL should stay below 130 milligrams per deciliter. But if you have atherosclerotic cardiovascular disease, your LDL must stay below 70 milligrams per deciliter. But some people take cholesterol meds regularly, so why won't their LDL go down? When treating high cholesterol, doctors usually start with the first-line drug, statins. They're the first-line, best-supported LDL treatment. They are also covered in Taiwan, but statins treatment also have limits. They mainly work by reducing cholesterol production, causing the liver to make less cholesterol. The liver then senses it's running low, so it pulls more LDL from the blood. Clinically, we often see this. The patient's already on statins, but LDL isn't low enough. Even if you double the dose, LDL may only drop about 6% more. That's the 6% rule, and everyone's metabolism is different. Some people just don't respond well to this pathway, and for some, higher doses bring side effects such as muscle soreness, weakness, cramps, and elevated liver enzymes. They may never reach an effective dose. So what then? We add a second, insured option, ezetimibe. What does this have to do with the liver? The answer? Nothing. It works in the small intestine, blocking the NPC1L1 transporter, so cholesterol can't get absorbed. It cuts cholesterol absorption by about 54%, more than half. Once gut absorption is blocked, the liver's cholesterol stores drop. So the liver compensates by making more LDL receptors to grab LDL from the blood. LDL drops even more. That's why we like pairing statins with ezetimibe. One cuts production, the other blocks absorption. The liver can't compensate, so it makes more LDL receptors to clear LDL. That's real synergy. We also have fixed-dose combo pills like Atozet, Cretrol, and Tonvasca. But honestly, for many high-risk patients, even both drugs together aren't enough, especially those with stroke, heart attack, diabetes, or a family history of early heart disease. Their vessels can't heal fast enough. What they need isn't kind of low. It has to be really low. As I said, their LDL should be under 70. And for the highest risk group, under 40, that's far from the usual 130, a whole different level. So if we really want to drive LDL down, what's next? The third path to fighting LDL is LDLR. The key lies in your liver, the organ that clears LDL. On liver cell surfaces, there are receptors called LDLR. It's like a recycling station that pulls LDL from the blood back to the liver for breakdown. So imagine more stations, faster LDL clearance, fewer stations, higher LDL. Simple enough, right? But for many people, those stations get stolen. The thief is a protein, PCSK9. It latches onto LDLR and drags it straight to the shredder, so it can't return to the liver surface. To keep those stations running properly, we need one of the biggest breakthroughs in cardiovascular care: PCSK9 inhibitors. PCSK9 inhibitors have nothing to do with SK2. Not a pill, not a supplement. They're injectable biologics, given every 2 to 4 weeks. The two most commonly used are monoclonal antibodies, Repatha and Praluent. They work directly. They block PCSK9, the thief, stealing your stations. PCSK9 promotes LDLR breakdown after it returns to the liver. Once you block it, LDLR stays on the cell surface and keeps recycling, clearing LDL each time. In the 2017 Fourier trial and the 2018 Odyssey Outcomes trial, PCSK9 inhibitors cut LDL by about 50%, sometimes even 70%. And not just the numbers, heart attacks, strokes, and cardiovascular events all fell. Put it this way, it's not just a good score. You actually got into top schools. That's great. But PCSK9 inhibitors have one downside. You need a shot every 2 to 4 weeks. For some patients, that's too often. Could it be stretched to one shot every 6 months? So researchers asked, what if instead of blocking PCSK9, we stop it from being made? That's where siRNA came in. The flagship drug is Lecuvio. Its mechanism is very different from monoclonal antibodies. Antibodies stay outside the cell. Once PCSK9 appears, they grab it. But siRNA goes inside the liver cell, finds the mRNA for PCSK9, the blueprint, and shuts it down. It doesn't damage the cell. It just blocks the message. Once the message is off, the cell stops making PCSK9. Then nothing is left to break down the stations, the LDLR. What's siRNA's biggest advantage? It works inside the cell. Unlike antibodies that work outside, it isn't cleared as fast, so it lasts much longer. In practice, the dosing schedule is first shot, Second shot 3 months later, then once every 6 months. That's just 2 shots a year to keep PCSK9 suppressed. LDL reduction stays around 50%. But a reminder, PCSK9 inhibitors and siRNA are not for everyone. For example, if your LDL is mildly elevated and diet and exercise work well enough, or if your wife is pregnant or breastfeeding, we don't recommend this treatment. Also, PCSK9 inhibitors need regular injections, so they're costly. They're not fully covered yet, and siRNA still requires monitoring of the liver, kidneys, and injection reactions. And for now, it's self-pay only. Honestly, not everyone will pay for it. So it's not about whether you can use it, it's whether you need it. Your doctor needs to. Look at your LDL level, risk category, and treatment history as a whole to decide if this is right for you. But in some cases, a patient's LDL is dangerously high, off the charts. The risk is immediate. There's no time to wait for medicine. So in these extreme cases, we use a direct method, plasmapheresis, also called LDL apheresis. We run the blood through a machine to filter out LDL, then return the clean blood. It's so fast that sometimes one session brings LDL back to normal. But this is definitely not for most people. And plasmapheresis isn't a one-and-done fix. LDL comes back after a while. It's really more of a treatment than anything else that needs repeating. It can also strip out beneficial antibodies, causing a short-term drop in immunity and blood pressure. Throughout the process, a medical team has to monitor you. By comparison, PCSK9 and siRNA therapies are much safer. You just need regular liver and kidney checks and to watch for injection site reactions. But if you really want to know more about plasmapheresis, who it's for, how it's done, the risks, leave us a comment. We'll do a full deep dive in a future episode. After all this, when it comes to lipid control, we really can't keep using that old one-size-fits-all idea that any drop is good enough. Personalized health risk management matters most. If you've been following our channel, you'll know that today's PCSK9 discussion is only one small part. Don't forget, to truly beat metabolic disease, proper diet and regular exercise will always be your best strategy. For more medical breakthroughs, stay tuned to our show. Remember to subscribe and join Team Health. Let's stay healthy together.